on the patient intensity index. We may have time for other items, but we really didn't have much more than that in terms of the agenda today. So we'll start off with the talk by Dr. Shaikh on UTI and what's new. And for those of you that don't know Dr. Shaikh, he is a professor in the Department of Pediatrics at the University of Pittsburgh School of Medicine in the Division of General Academic Pediatrics. And I think it's easy to say that Dr. Shaikh is fairly prolific. He's had a lot of high impact publications around the treatment of common infections, which is a focus of our network as well. So he's done many clinical trials and important observational studies that's really provided the evidence guiding how we manage urinary tract infections, but also common infections such as otitis media and sinusitis. So it's a real honor to have Dr. Shaikh here to speak to us. And if you don't know, he's also been really supportive of our work and provided, is a co-investigator on the routine study, which is looking at imaging after first episode of the urinary tract infections in febrile infants. So I'm going to hand it over to Dr. Shaikh for his presentation.
Thanks, Sanjay, for that introduction. I have some sort of RSV, I guess, or something similar that I caught from one of the kids in clinic. So I'm sort of like wheezing a little bit. So I don't have that many slides for that reason, one reason. And then the other reason is I would like to keep this like open for discussion because this is a controversial area. Nobody really knows what to do. So I would like to have it open and we could discuss things. So let me see if I can share my screen. Yes, so I wanted to focus on a few things today. So the first thing is how to define UTI, which is a constantly changing and complicated thing. The more you look at it, the more it changes and it gets more complicated. And then talk a little bit about new things related to the diagnosing and treatment of UTI. And when I'm saying new, I mean things since the last publication by the American Academy of Pediatrics in 2011. So I'm sort of reviewing things that are not so new and then some things that are really new. And I'm sort of going to focus on young children because that's sort of the most confusing because they don't talk and everything is more confusing. And I don't really have the answers. Whatever I'm saying is my understanding of the data and my recommendations, but doesn't mean that I know there's a guideline committee that's writing a new guideline now. I'm not sure what they're doing. And I'm not speaking for the AAP or anybody else. So these are personal ideas. So just to review, the 2011 guidelines talked about three things: who to test, the definition of UTI, and how long to treat. And in the who to test part, they said you should use these 5 variables: the race, age, maximum temperature, duration of fever, absence of a source of fever, to decide who to test. And for the definition of UTI, they sort of made big changes in that definition. And they said we should require pyuria for the diagnosis, which was sort of new. And they recommended a cutoff of 50,000. And for the treatment part, they recommended treatment for 7 to 14 days. And these are the areas, they said other things in the guidelines, but these are the areas that have been mostly impacted by recent developments. So I'm going to focus on these 3, and then we can discuss anything else that comes up. So first, about who to test. So since 2011, there's been this new calculator that we've developed, and it sort of does the same things that those 5 criteria did, but it has several advantages. One advantage is that it does not use race in the calculations anymore. So we took race out. This is version 3 of this calculator, and what this calculator does is on the left side, it tells you which kids you might want to get a urine from. And then on the right, it says which kids you might want to treat. So it helps with the testing, who to test and then who to treat part, both of them. So the left side is for the who to test. And you could see You enter the child's characteristics. So age is less than, let's say we have a kid who's less than 12 months of age, has a maximum temperature that's not higher than 39, has a history of UTI, is a girl, and has no other fever source, and does not have fever for more than 48 hours. And then you put these things in and you calculate, and it gives you some probability. So it's telling you that just with these things, the probability is around 21%. And then you, as the doctor, can decide, I want to get a urine sample or I don't want to get a urine sample. So it's sort of different from the AAP method where it says get it and don't get it. It gives you a number that you can decide what to do with your patient and discuss it with the patient maybe. It does give sort of vague recommendations as to what to do. In another pop-up screen that I didn't put here, but it does give some sort of recommendation, but it leaves it open for input from the parent and from the doctor. And then the second part, you put in your UA things. So here the child had no nitrites and 2+ leukocyte esterase, and when you add that, the probability of UTI goes up to 71%. So you can decide I want to treat or I don't want to treat. So that's also another probability that you get. Because it's not so clear, like what does a 1+ do versus a 3+ leukocyte esterase or a white blood cell count of 75, and you don't have to enter the stuff that you don't have. So if you didn't do a gram stain, you don't need to enter it. It will calculate it. So we talked about this. It estimates the probability of UTI. It doesn't use race. It's been externally validated in a few different hospitals. And then, as you mentioned, in Ottawa, they're doing another validation, which is prospective. They're halfway through. So this thing will probably, this been changed 3 times already. I'm assuming it will be changed again based on new data. And it's supposed to be, it's freely available online. Yeah. And I think it's a useful tool if you're not so experienced, especially if you really know what you're doing, you probably don't need it. But if you if you're a trainee and you're not sure who has a UTI, this might help you figure out the percentage or probability of your pretest probability and your post-test probability. Any questions about this UTI calc?
Nadir, how do you know, like, in terms of the thresholds that the percentages are created? I guess that's like in terms of, is there any data on what
Yeah.
people when people would like send a urine based on that, or when? I know it's
Yeah.
probably about value-based judgment.
Yeah,
Sounds
yeah.
like,
This is
yeah,
a very good question and difficult to answer because
yeah,
um, different doctors will have different probabilities. So, like, let's say the probability of UTI is 6%. Would you check a urine in that patient or not? Or let's say it's so the way we went by that, we sort of did look at some literature that suggested like 1 or 2% is what doctors use, but we sort of didn't know if we should believe that or not. So we sort of took this other approach where we're like, what if you want to detect 95% of UTIs, what threshold should you use? And it turns out if you want to detect really 95% of UTIs, you have to check a lot of kids because the symptoms are non-specific. And that means you have to check anybody with a probability of 2% or less. So the left side of the screen will show 2% or less. But then we talked to some clinicians, they're like 2% is sort of lame. And so then they're like, maybe we can't, maybe it's too difficult to detect 95% of UTI. So what if we use 90? So if we use 90, that probably would become 5% in most of the places that have validated the 5% probability. In my mind, above, if you go much above 5%, because symptoms are non-specific, I would like to have 50%, but it's not possible because the kids don't talk and it's
right.
just vague symptoms. Everybody has fever. So you're going to miss UTIs unless you're very liberal in your testing. So if you don't want to miss more than 10%, that number should be close to 5%. If you go much over 5, you're going to miss a lot. So that's what the calculator, the pop-up says. If you're over 5%, it says most doctors would check a urine over this percent. And if you're between 2 and 5%, it says it's borderline. We don't just, you're going to miss some, but not that many.
Okay, thanks. That's helpful. And was it was this created, the calculator, based on like what practice concept? Was it ED, primary
Yeah.
care, both?
Yeah, it was mostly ED because we couldn't get enough. I mean, we did validate it in a primary care sample, but we didn't publish that. So the published stuff is based on the ED work. And the second hospital that did it was Lurie Children's, and they did it also in the ED. And I think they're doing it in the ED in Ottawa. I
How
haven't
do I,
seen
yeah.
data.
Yeah. Right.
It
Thanks.
seems like the numbers are, you need a lot of people being tested, so it's hard to get all these little practices, and the data is just hard to find. I'm sure some place like Kaiser is interested in using this, so maybe they'll find it. They have tons of patients. Somewhere like that, they could probably validate this in 15 minutes or come up with a better one. Uh, so the next thing is the definition of UTI. So as I said, the pyuria was required for the diagnosis, um, which means no pyuria, no UTI. That's basically what the American Academy of Pediatrics said. If it's required, that means you have to have it. So UTI means you have to have pyuria, which was something new and unique to that guideline. And so the question is that a good idea or not? Um, so pyuria is assessed by a dipstick usually, or if you're in a hospital, then you have a machine that counts the WBCs. Um, the sensitivity and specificity of these things are well known. They've been studied for forever. So the test for pyuria has been around since the 50s. That many people have studied it, compared it to culture. So it has a sensitivity that's known. It's 79, 80%, somewhere in that range. It's not great. We think it's a great thing, but it's, if you look at the data compared to culture, the sensitivity is 79 to 80 or 81 or some. Different studies vary, but that's the from a meta-analysis of 90 studies. So that's very well studied. And so by that definition, if the sensitivity is 79%, that means you will miss 21% of children with a positive culture, which is about 1 in 5 kids. So do these 1 in 5 kids have a UTI or something else? If they have a UTI, the AAP was wrong to add this requirement because we're missing kids with a UTI. If they have something else, maybe they had a reason to put this in. So what something else could they have, these 1 in 5 kids? So the 2011, the rationale used for the 2011 guideline was that UTI is an infection and it should be accompanied by inflammation. Therefore, if there's no pyuria, there's no UTI. Therefore, the 1 in 5 kids with a positive culture probably have asymptomatic bacteria or contamination, which were the only things that really cause a positive culture. So could 1 in 5 kids have ABU, asymptomatic bacteriuria, or contamination is the question. I think that's relevant. And asymptomatic bacteriuria is something we talk about all the time, but it's actually how many cases have you actually seen that are you're sure this is asymptomatic bacteria? When people study this in schools, like they go to school, everybody lines up and pees in a cup, or there's been many studies like that. And when you look at the number of children who have it in these well designed representative studies, the pooled incidence is about 2 in 1,000, pooled prevalence, sorry. So it's very uncommon to have like large number of organisms in your urine. Um, and these studies, yeah, so 2 in 1,000, this cannot explain the 1 in 5 kids who come to the ER who have a positive culture. I just can't see how that would explain it. And then contamination is also something we see a lot clinically. It's not rare at all, but with catheterized samples, it's more rare than any other kind of sample other than suprapubic. So catheterized samples is not common to see. It's common to see some sort of aberrancy, like there might be a few organisms of another kind. You see 100,000 E. coli and 5,000 of something else, or that's not uncommon. But contamination, as if you have some kind of other organism like E. coli 100,000 due to contamination, that's sort of far-fetched in my opinion in a large number of kids. Maybe a few kids have it, but usually contamination happen when you have contamination. there's multiple organisms because the catheter touched the skin or there was a poop or something. So usually there's multiple organisms, and then organisms that are introduced late. So when you culture it, they grow less than something that's been there and multiplying before you got the culture. So usually the counts are low and there's multiple of them. So to contamination in my mind cannot explain this high number of children, the 1 in 5 kids who have a pure growth of a single organism at high counts. Should we pause here to discuss this like complicated and controversial area? Probably a lot of.
Just wondering if anyone has any questions or reflections on this area of controversy. So Nadir, I guess the clinical scenario here could be like, say, like if you're a hospital-based pediatrician, you have like a 8-week-old who has fever, is vomiting, comes in, has no pyuria, but it's growing E. coli,
Yeah.
the urine.
Yeah. So in my mind, I'm gonna go in the room and tell the parent whether the kid has a UTI or not. I'm gonna say, okay, this is like my calculator tells me this probability is 30% UTI. I didn't do any UA or anything. I think this kid might have a UTI. I'm worried about this kid. I get a urine, it grows E. coli 100,000. It doesn't have pyuria.
Right.
Am I gonna go call this parent and say stop the antibiotics? The AAP said there's no pyuria, therefore your kid doesn't have a UTI. I just don't feel comfortable doing that. I don't think it's logical to have that kind of probability just to start with, and then you have another thing which is a positive culture, and all that information is thrown away because the pyuria is positive or negative, and we know that pyuria is not the greatest test because it's been studied 100 times and it just doesn't, it's not a definitive diagnosis. It's a quick and dirty screening test. So we're using a quick and dirty screening test to make the ultimate decision whether a child has a UTI or not, whether they should get any imaging, whether they should do all this stuff based on something that's a screening test. And somehow the screening test was elevated to the gold standard by requiring it. We're sort of messing everything up, in my opinion.
And then
there's a large number of kids that affected by this.
Yeah, the other point, like in terms of hospital care, when we're seeing them, once the urine culture is positive, most of the infants are already on antibiotics, so even repeating it is not usually helpful. Like you have to go with what you have in front. There's a couple of questions here. Sorry,
great.
To see who. There is Shamama and then Suzette. Shamama,
I just had a quick question. I know this might be very rare, but was there anything done on patients who have conditions such as like neutropenia where pyruvia isn't present, and then they do have a UTI?
Yeah, I mean, I don't have data on that, but that's yeah, it could happen. Maybe they got a dose of whatever the parent gave them in the fridge or something, or maybe the urine was dilute, or maybe they were neutropenic, they can't mount a response, and also there's data showing that different organisms cause different amount of pyuria. So if the child has enterococcus and they don't have pyuria, that's sort of pretty common. So to have one definition, that's sort of, there's some biological reasons, like you mentioned neutropenia, then there's a different organism issue, and there's just timing issues. Like if you check it really early, maybe you haven't had that many white cells come in yet, but there might be tons of E. coli. Do you want to send a kid home and check him the next day? It's sort of difficult.
Yeah. Suzette?
Sure, thanks. Really interesting topic. What I understand is that the calculator essentially evaluates risks and gives you a sense of probability or prediction in terms of whether the patient might have a UTI. I'm wondering about newer technologies that might be used instead of, looking at pyuria or, cultures, that type of thing, that might better detect what's going on in the urine in terms of a serious bacterial infection.
Yeah, there's new biomarkers that have been suggested, and they seem to be better than pyuria. So there's one called NGAL, neutrophil gelatinase, and it seems to work. So I think over time, what you're saying will happen, which is some new marker will be found, hopefully, or we have to do cultures. So there are new markers that look better, which is another reason I don't think having a marker, tying your definition to an old marker is really helpful, because maybe the marker is just not up to it, and maybe the idea wasn't bad, but their marker was not the right one.
Right. We'll go one more question, Pat Parkin.
Thanks for so far. I had a couple of questions for clarification. Not totally up to date on this topic. When you say pyuria, are you saying that that's the leukocyte esterates test, the dipstick?
In most places, that's what we get, a leukocyte esterase in the outpatient. But in the hospitals, they have a machine that counts the white cells. So both of those perform similarly. So I used to think, oh, the white cell counting is so much better. But if you look at, and the newer machines might be so much better than the older machines, like the way we used to do it with the microscope. But it seems like it's sort of 79, 80, 81%, they're all in the same range. Like if you look at this machine versus that machine versus hospital versus leukocyte esterase. So I sort of lumped them into this pyuria as an umbrella term.
Great. Okay. Thanks for the clarification. The reason I was asking it, I seem to remember an era when we did get microscopy and we did get a white count. I found that really useful. That's what I would call pyuria, but I wasn't very impressed with leukocyte dipstick. And yeah, I mean, and then the other thing I just wanted to ask, well, it's not really a question. I think I always felt contamination actually was, you've written that it's rare, and I take your point, if it's a single organism and it's a high count, all of that I would agree with. But it seems to me that contamination is actually pretty common.
Yeah.
And I often think, I mean, it's not us physicians who are doing the catheter samples. It's usually very experienced nurses, but it's an extremely difficult procedure, I would think.
Yeah.
And not that difficult for contamination to occur. So
yeah.
I would have thought contamination was actually quite common.
Yeah, it is common. I agree. Maybe I used the wrong term, but I just don't think it's, even if it is contaminated, you won't know if it grows 100,000 E. coli. How would you know that it's contamination or not? It's sort of hard to convince people that that's the case.
In that scenario you described, I entirely agree with you.
Yeah.
But anyway, thanks very much.
Thank you. Okay, I think we probably sort of talked about this argument with the UTI. So I think there is a problem with the way that the UTI definition was done in the 2011 guideline. There's a new committee trying to come up with a new definition. My recommendation would be to not include pyuria because it's not a great marker. We should do a culture and just go by the culture, and not change the definition to include pyuria. Not required. We can use pyuria. That's very helpful to have the count or the WBC count or the dipstick, but to require it is a whole different thing that sort of messes up how we diagnose things. And we're changing the gold standard. And the other implication of this is hospitals, at least in the US, are not doing cultures anymore, which is sort of why I'm sort of getting more vocal about this, because I can't even get a culture on a kid in our hospital unless the UA is positive, because they're like, why should we spend money if the AAP says this is not a UTI? I don't need to grow it because it's not useful. So they're very happy about this definition because they don't get to do cultures are not done anymore. And it's hard to know what happened in a kid. You did a catheter which was invasive, but you can't get the result of the gold standard, which doesn't make sense to me. Okay, I think we can move on to another topic now. So the second thing about the definition is the cutoff to use 50,000 for catheterized samples is what they recommended. There's some evidence to support the cutoff of 10,000. to establish a cutoff, you need a gold standard. So we didn't have a gold standard. Like for example, for cholesterol, we know cholesterol of 250 or whatever, LDL of more than 200 is bad for you because you die more often. So they have an outcome mortality, and then they studied the people who died, and they're like, this threshold is related to mortality. And there's no such similar thing for culture. We've never had any other thing to use as a gold standard for the culture. We've only had the culture. And based on new technologies that are available, one new thing that's available is microbiome analysis, which basically, instead of putting the thing on a plate and counting and looking at what grows, we look at all the DNA in the urine and see that what's in there. So all the organisms in the urine the DNA will be known, and it's sort of the amounts of the DNA are also in there. It's not exactly quantitative, but it sort of gives you a relative idea of what's the predominant organism. So we did the study where we compared urine culture to microbiome analysis, and the microbiome analysis was the gold standard. We just asked what would happen if we use this as the gold standard instead of the culture. What would be the threshold on the culture that would match with the microbiome analysis? And we found that at a threshold of 10,000, almost all children with abundant pathogens had counts of 10,000 colony forming units per ml. So at 10,000, the two tests match perfectly, the microbiome analysis and the urine culture almost perfectly. And at 50,000, lots of kids, about 20% of kids with significant amounts of uropathogen DNA. So they had lots of E. coli in their urine, but the culture didn't grow 50,000, it grew 40,000 or 30,000. So in this study suggested that maybe we should be using a cutoff of 10,000 because we're declaring kids who have lots of E. coli in their urine as a single predominant organism as not having a UTI, just based on this count, which was based on no gold standard study. It was based on guessing what a good threshold would be. This is not really a definitive study because more studies are needed to show that this is reproducible, but at least there's some data now with a different gold standard or a different standard, which gives us a perspective on what to use for culture. Another important piece of this is this study by Sverkerson, I quote on the bottom there. They scanned children with counts between 10 and 50 and found a lot of kids with that range had pyelonephritis that you could see on the scan. So just because they have 40,000 doesn't mean they have a mild UTI, and we don't need to call it a UTI and ignore it. So they showed that a good number of those kids had pyelo, and which also suggests that we should be using a lower cutoff. And so based on this study, my recommendation would be to use a cutoff of 10,000 and be skeptical of using 50. If it's 40, doesn't mean they don't have a UTI, because maybe again it was early or other reasons it was dilute, or so. maybe take a 2-minute thing for any questions about this. Also controversial.
Any questions from anyone?
I was more thinking, Nader, as you're mentioning these, is how we think, clinically in binary, disease present, where in so many ways these are continuous values that we sort of arbitrarily define a cut point, and how much you think there's the need to integrate the clinical in addition to the diagnostic test as opposed to test alone.
Absolutely. Yeah. Even the 10,000 is probably wrong, because anytime you pick a cutoff, there's going to be kids below and above you. You have to sort of use your clinical judgment. So that's sort of the problem with guidelines. They're easy to criticize, but hard to write, because they're going to say something, and there's always going to be kids underneath that margin because of what you mentioned. There's you sort of have to go with your clinical over anything the guideline says or any cutoff that is finally agreed upon, because cutoffs are just like that. Most kids above it will have this, and most kids below it won't have it, but some kids will. So you have to use your clinical judgment always as the first thing, in my opinion. Which was okay for the 50. That's why the 50,000 sort of works, because most of the kids don't have a UTI under 50,000, but some kids do, and it seems to be larger than we realized.
Nadir, when we within our network, we looked at what labs report, and there's a lot of variability,
Oh, yeah.
and a lot of them report only in units of 10, like 10,000, 100,000.
Yeah.
And there's a couple that report 50,000. So that was
Yeah.
another issue. Yeah.
Yeah, that's another, yeah, another issue, because the labs don't want to count all the dots on the plate, so they might be happy with the 10. So the last thing is a scout study, which is the treatment duration for UTI. So this was a study comparing 5 versus 10 days of antibiotics. So on the left, you could see that we had 639 girls and 25 boys, and the age range was 2 months to 10 years of age. This was a randomized trial with 2 children's hospitals and their associated EDs and outpatient clinics. And it was Philadelphia and Pittsburgh. And 328 got standard dose, which was 5 days of, which was 10 days of antibiotics. 5 days. They first got their 5 days. Everybody got whatever the doctor prescribed for 5 days, and then on day 5 we switched them to either placebo or another 5 days. So they got their one of these antibiotics that the primary doctor had prescribed, and then the other 336 kids got placebo for the second 5 days. And the primary outcome we looked at was UTI between day 6 and day 14. So we basically asked if you got longer course, were you less likely to have a breakthrough UTI at the end of your treatment? And we found that treatment failure for both groups were really, really low. It was 0.6% in the standard course group and 4% in the short course group. So very few kids failed treatment. So very kids had a symptomatic UTI anytime close to the end of treatment. So there's 2 ways of looking at this data. One way is to say both of these are really low numbers. The kids do fine. If you get 5 days or 10 days, everybody's okay. So just give them 5 days. The other way is like you say, okay, 0.6 is not exactly like 4.2, and their difference is significant. So short course is slightly worse than standard course, and maybe maybe it's a little bit better. Standard course is a little bit better. So we took the first view, whereas both sides were much lower than what we predicted. We predicted like 5% for the standard course and 10% or 15%, I forget, for the short course. So we were sort of surprised that it was so low. And we concluded that 5 days is probably good enough for most kids. So that was the scout study, was sort of also a little bit not black and white as we like. It did turn out to be significant, but the differences were very low. So if you calculate the number needed to treat, it was very low. I forget what it was.
Nadir, are you okay to take a question?
Yeah.
Suzette?
Nadir, I'm curious, in that day 6 to day 14 visit, how was that UTI diagnosed?
Yeah, so they had to have a positive culture, and they have to have had some sort of symptoms or some reason to have had it done. So we didn't just we didn't count we didn't count it as a UTI if they had no symptoms. The child was completely fine. There's nothing wrong with them, and we got a urine sample, and then it grew something, because we didn't think it was ethical to be catheterizing these children, to randomly, just routinely catheterizing all these 600 kids to see if they had any bacteria, because we're like, we don't really want to treat bacteriuria at the end of treatment. Was not so relevant to us, and we didn't think it was ethically justifiable to do catheterization. So we did think it was justifiable if they had symptoms. So if they had symptoms at the day they came, everybody came in for a visit at the end of treatment, usually between days 11 and 14. And then at the visit, we sort of asked the parent, "Well, how's your child and what's going on?" If they had anything, then we're like, "Okay, let's get a urine." And then we would do a catheterization, get a urine. And if the urine was positive, that was a UTI. And we
Great,
did look
thanks.
at other outcomes. We did look at bacteriuria using a bag, and we looked at positive urine culture without symptoms. And those things were not so interestingly different in the two groups either. So the primary outcome was UTIs, which means symptoms and positive urine culture. But we did look at urine culture alone, symptoms alone, all that stuff alone, and they didn't really suggest that one treatment was better than the other, really. So I think that's pretty much what I had.
Great, thanks, Nadir. Just gonna see if there's any. Carla, do you have a question?
Yeah, I just going back to the threshold and lowering it to 10,000. Does that mean you would administer antibiotics for those that had 10,000 and more? Like, would you be administering more? The chances of giving out antibiotics, would it increase because
Yeah.
of the change in the threshold? And then I was curious about the repercussions of that. Like, would that mean
Yeah.
reoccurring UTIs, and what does that mean for antibiotic resistance?
Yeah. So I was worried about that too. Like, we were gonna lower the threshold, and we're gonna treat all of these kids who are sort of borderline. Some of them probably have a UTI, some of them don't, and we're gonna cause all of this antibiotic overuse. But if you look at the data, I don't know if it's on these slides or not. We're gonna have to go back. Yeah, I don't have the specificities there. So the sensitivity was definitely better with the 10,000. You miss 20% less kids. But the thing that was surprising was the specificity did not change much. So you're not going to be treating a lot of kids without a UTI. So when you calculate like how are these guidelines going to increase antibiotic use, it wasn't increasing it by that much at all. The specificity almost stayed exactly the same. So that means that we're just changing the sensitivity. Most of the kids that had between 10 and 50,000 had a UTI according to the microbiome analysis, and they're not being overtreated. And not many kids were having nothing in their urine, and we were just treating them. So it wasn't going to cause a lot of antibiotic overuse, because not many kids have, these 20% have it, but not many other kids have it.
Could you argue then by catching more kids, you're reducing the risk of repercussions of not treating it, and maybe saving dollars?
Yeah, I think that's what we concluded. The sensitivity improved, but the specificity didn't change. So we were seeing it as, okay, we are catching more of the true positives, but we're not adding to the false positives so much. And probably more important, because these are kids with fever and they're sick, and we did a catheterization on them, and the cutoff and in those children, it seems like it makes more sense to not miss kids, especially because we're really looking for a source for the fever, and they have this pathogen in their urine. And in those kids, it doesn't seem like it's going to cause a lot of overtreatment either. So it seemed like a win-win situation to us.
Thanks.
Perfect. Thanks, Nadir, for coming and speaking to our group, and really appreciate also your format of because it allowed for some interaction and discussion, especially on these controversial topics. It's great to have this discussion embedded within the talk.
Thank you.
Thanks so much. And you're welcome to stay on.
Okay, great. Thank you.
And then, so for the next remaining time in our meeting today, Dr. Suzette Cooke, who many of you know is a hospitalist and very involved with the national efforts around PHM fellowship programming, and is also the PD at Alberta Children's Hospital for Hospital Medicine, is going to speak to us about a follow-up around the patient intensity index, which she and her colleagues spoke to us, I think, last year about.
Thanks, Sanjay. And thanks for the previous talk. Really enjoyed that, and especially the gray zones that you're talking about, so helpful. What I'm hoping to speak to you today about is a study that we have started and presented this at PIRN in the past, and just want to give you a little bit of an update and where we're going next. So we're looking at something called the Pediatric Intensity Index, and we're seeking to develop and validate a tool for pediatric hospital medicine. You can see the investigators include Dr. Gemma Vomero, who's on the call, Dr. Leah Restivo, who is currently on maternity leave, but a section member within our section, and myself. So just a little background information to refresh your memories. We know that pediatric hospital medicine, or more inpatient pediatric medicine, I know it's called different things in different parts of the country, but we are talking primarily about, I think, the same thing. And we're recognizing that children admitted to pediatric hospital medicine wards have increasingly more acute and complex needs. And this is owing to advances both in critical care, also neonatal care and surgical care. I think there's an improvement in our medical delivery and also nutritional regimens that our patients have been on, right from, for example, some of them prematurity. And it's allowed for increased survival of especially our more fragile patients, but really all patients. There's also the concept not only of medical acuity and complexity, but social acuity and complexity. And if you just consider the amount of immigration to Canada in the past year, that alone is putting increased pressure on our teams in our inpatient wards, from the point of view of understanding the past history of the patient, possibly needed language line more, because many of the patients and families we now treat speak, other languages, and we're needing interpreters and so on. And of course, we know the mental health burden that is facing families, which is very significant. So this tool is not just intended to measure acuity and complexity from a kind of medical point of view, but actually the social aspects as well. So today we really don't have a tool to characterize this. And if you think about the emergency department, for example, all of our emergency departments, we would know that there's something called a CTAS score, which is a way of categorizing the patient in terms of their priority of whom they should see first. So for example, a trauma patient would be a CTAS 1. That's going to be like an urgent need to see immediately type of patient. And then all the way down, I think it's to CTAS 5. So there are tools within emergency medicine and pediatrics. There are some tools within pediatric medicine to assess medical complexity. And folks like Aya and Colin, and I know Sanjay, you've been involved in some of those studies to help kind of look at those characteristics. There are also early warning signs for clinical deterioration, like the PEWS tool, and there are some nursing resource allocation types tools. But there's really no current strategy that supports the classification of patients in pediatric hospital medicine. And I'm talking about hospitalized patients, not patients in clinic, just for the sake of this particular focus. And that then challenges us because it's hard to plan healthcare resources, and it's also difficult to justify the active needs that we have currently and those that are emerging. So the gap really creates three issues. There's that lack of awareness, certainly I think at many sites, provinces, and at the national level, and also at a societal level. So if any of us went out on the street and shared with people the types of patients that we have in our hospital, many of them would be shocked at the level of complexity in particular, but also the acuity. We recognize that there is sometimes insufficient and inappropriate resource allocation. So what is understood by the site or the healthcare organization or the province or nationally, but as we know, healthcare is delivered provincially, it's lagging behind the current understanding of what is needed. So what are the needs right now out on the wards, for example, versus what is the understanding of what those needs are based on data that might be 5 or 10 years old. There's deficits in short and long-term planning that result, and then, of course, the allocation of healthcare delivery. So all of us are kind of in the have the awareness that you need to have data to be able to justify what some of your impressions are or your hypotheses are. So this is an effort to seek better data. We know from previous studies that appropriate medical resource allocation is linked to improved patient safety, hospital efficiency, and satisfaction of patients and families with their care. It's also associated with reduced length of stay, medical errors, unnecessary investigations, and morbidity and mortality. Those sound like really good things to target, and we hope that this tool can help to do that. So our primary objective is really to develop this tool that contributes to medical care needs. So understanding what are the patient factors that contribute to the needs of that patient. And in this case, we're focusing on pediatric tertiary care hospitals. This is a first step in recognizing that there are other hospitals and community hospitals who care for these patients. This is a first step to look at the tertiary care level with, you know, an eye in the future to look beyond that. So we had to set our, you know, our limitations at some level just to be able to make it manageable. So this is where we're starting. We have secondary objectives to pilot the tool with patients admitted under teams at tertiary care hospitals during a 1-week interval at 3 different periods during the year. So as you know, the types of patients we might have in hospital this week might look a little different than they do in September or in June. And that's obviously partly the seasonality. We would want to compare the care needs of different teams on a given week, and based on the outcomes of the tool, describe when a particular team's patient care needs require medical staff to extend their shift. So we're also familiar with individuals maybe having an 8 or 9 or even 10-hour shift, but it's going beyond that. And many of my colleagues are working 12 to 14-hour shifts right now, but that's not captured anywhere. And so we're trying to capture that somewhere. And then based on the outcomes of the tool, describe when a particular team's patient care actually those needs surpass patient safety. So these are like big eye in the sky type things, but we're just trying to get a bit of a lens as to what's going on in this landscape. This study is already approved and we've already undertaken the first step. So this phase 1 domain item generation. When you're looking at a new landscape like this and trying to characterize what's going on, we need experts in the field to be able to generate the items that are relevant. So this was partly done through a preliminary literature review done by Dr. Restivo and supervised by Dr. Romero and myself. And then we conducted some semi-structured Zoom focus groups to help identify what should be included when we're talking about medical acuity and complexity and social acuity and complexity. And so we've already done 2 focus groups within our center. And our next step is to recruit 8 full-time physicians from across Canada with good representation geographically to contribute to a focus group to further extend the domain item generation. And this has been, for the first step has already been transcribed and analyzed for core themes. I don't want to be leading in presenting that data yet because we need to move to that next step of domain item generation for the national group. The next step after that will be the Delphi methodology, whereby we, again, geographically recruit physicians from different parts of Canada. At this stage, we're looking for individuals with more experience. So in the previous, we're looking for individuals with a minimum of 3 years experience to contribute to the focus group. Here, we're looking for individuals with a minimum of 7 years of experience practicing in that setting. And in particular, we would like number one member from each region as defined here with a focus on acute care in this setting. And then we'd like 2 additional physicians from different regions who have a particular focus on children with medical complexity to make sure we fully capture that. So we'll use a minimum of 2 rounds on the Delphi methodology and potentially closer to 3 rounds. And so we're really looking at developing some content validity, which domains are most relevant to keep in the final tool. Currently, we have approximately 17 domains, but once we have additional item generation at the national level, that may increase. Then the goal of the Delphi is to ask people, which of these should we keep in the final tool, recognizing that any tool that you use for scoring has a cost. And I don't mean just a financial cost, but if someone's going to actually characterize these patients on a tool, that's a time cost for the physician to do that. Naturally, it would be exciting if we could utilize something like Connect Care to harvest that information, that we could say, here's the tool, could it harvest 10 of these items, for example, and that it automatically generates that information. So that might be a little bit of a point for the future, but it's something that's been in the back of our minds as more and more sites move on to Connect Care. So really looking at the domains, looking at selection options for each domain and the inclusion criteria for scoring. I'll just say as a PIRN member and being involved with the Delphi methodology and Catherine Walsh at Sick Kids, who's been so helpful to us with helping us with the Delphi with the PHM competencies project that we presented at the PIRN conference. Super helpful to have her expertise on board and to help us make sure that we do this well. So many of you are familiar with the Delphi method. It uses a pooled intelligence of experts. We can use the Delphi Manager as a platform, and we would have survey questions associated with each round. This would take approximately a 3-hour total commitment, which would be 1 hour per round. So individuals would sign up, and probably at 3 points during about a 9-month period, we would have 1 hour per round. I'm not going to go so much into the phase 2 right now because I really just wanted to focus on the 2 items I had just discussed there. So here's where we're at in our timing. We had a bit of a delay with the pandemic for sure, but we have moved forward and completed the focus group and the focus group analysis. We're now at that stage of wanting to establish the national focus group for early 2024, followed by the Delphi in September of 2024. So my group always says to me, Suzette, what's the ask? And so just sharing with you, first, we're recruiting for the national focus group. We're looking for full-time physicians with a minimum of 3 years experience from pediatric tertiary care centers across Canada. And it is a 1.5-hour focus group over Zoom. So again, we're looking for 8 individuals across Canada, and there's a gift card that we can support as well for those that can contribute in this way. So that's the first ask. And then in September, the second ask is around the Delphi. So we're looking for representative physicians from each part of the country, and to really look at those various series in the Delphi to help us drill down into what we should keep for the purpose of this tool. And recognizing the increased time commitment, we have a larger size gift card, again, as a token of appreciation for that 3 hours of time. And that is basically it. Thank you.
Great. Thanks, Suzette, for presenting, and it's nice to see this project move along. In terms of PIRN being helpful for the project, we could also in the minutes send out the asks to our PIRN members, especially to those who weren't able to attend today, if that's helpful.
Be super.
Okay.
Thank you.
We have time for a couple of questions. We have about 2 minutes.
I said a quick question. When will the estimated dates be for the focus groups? Like the rough times you have to host them?
It would be late February and March, somewhere in that time frame. Yeah.
Okay.
We have everything ready from, we have approval for the study and so on, and we have all the letters. So it would be more just who would be on that list of individuals that we should ask.
Okay. And is there a plan to do a couple of groups?
Yes.
We're thinking of people just with like service, like when of like a roughly ballpark availability time? Because a few people that would be good to mention, but just sort of the rough times with clinical work.
Exactly. So as we did here in Calgary, we had 2 focus groups, each 4 people. And it works out beautifully. Like that number works well for a focus group as well.
Right. And then roughly what times, like I always do different time zones, we'll be kind of figuring out people based on who submits what works. Okay, perfect.
Exactly. So we'll run a doodle poll just to see what works and try to, again, get that representation.
Perfect.
Okay, so it's 2 o'clock right now. So Suzette, maybe just send that info to Carla to include, but thanks everyone for attending today, and thanks Suzette for providing the update, and let us know how we can be of help.
That's exciting.
Thanks so much.
Thanks
Thank you.
everyone. Thanks, bye.
Bye.
Take care. Happy holidays.
Bye.
Bye.
Happy holidays.